Hello, welcome to this PSPA webinar, which is part of our RC Expert webinar series. Today I'm joined by Fiona Turnbull. Fiona is a specialist movement disorder physiotherapist based at the Queen Elizabeth University Hospital in Glasgow, and she's a member of the Atypical Parkinson's multidisciplinary team. Our focus today is on questions asked about PSP and CBD and how these conditions most probably can impact on daily living. Hello, Fiona. It's good to see you.
Hello there, how are you?
I'm fine, thank you very much. Thank you for joining us today. Okay, before we dive into the questions, if it's okay with you, it'd be really good if you can sort of start by giving us an overview of the role of the specialist physio and how that supports them living PSP and CBD, and sort of a little bit about how that links in with working within the Atypical Movement Clinic.
Okay. Thanks very much. So yes, I've been a neurophysio for a number of years, with the past probably year to 2 years focusing more and specialising more within movement disorder, which has brought me into being a part of the multidisciplinary team for the Atypical Clinic. So I'm sure, as you already know, at the Atypical Clinic, the patients are seen by the consultant and the nurse, and then after that they come and assessed by physio. So they will come into myself, sometimes alone because their carer or their support person is in seeing the carer centre for advice, and then usually they would then join us after, because it's important to have the family support as well. So that's kind of where I fit into Atypical Clinic. The type of thing that we do at that clinic is mainly assessment, so it's really important to get assessed by a professional, ideally a specialist in the area. But we look at assessments of their obviously their physical abilities, so particularly looking at how their arms and their legs are moving, and obviously they're getting up out of a chair and they're walking, and specifically quite most of the time balance is a huge issue in both these groups. So a good assessment of that, kind of what level they're at, what kind of things they're managing, and obviously the home setup as well, and having a wee look at that, what kind of support they're going to need, any aids or anything. So really a good assessment, and for their first off meeting, and then when we see them back, we can kind of catch up on that and reassess if we need to.
Okay, lovely, great, thank you very much. Okay, let's start. We've got the questions aren't necessarily in order, they sort of come and go. These are questions that we've been asked on the helpline most of the time, I have to say. Some of them have been sent in to us specifically for today. Hopefully they're not going to challenge you too much, it should be all right. So we're going to start off, and I'm not sure whether this is relevant to PSP and CBD or more towards CBD, you must be able to say. The question is about joint contractures in upper limbs. Are they common? Are they possible? And is there anything that can be done to alleviate them?
I agree with what you say there. Yeah, certainly from my experience, more common in CBD, certainly with upper limbs and hands and things. But I have seen actually quite a lower limb one with PSP. So they're definitely possible. Quite a lot to do with tone, or the kind of inability to know where that hand is, so it's been kept in awkward positions, and then you've got the tone on top of that. So a few things contributing to it, but yes, definitely possible. To alleviate them, there's a few things, depends what stage you're at. Obviously, if it's been for a number of years, you will have shortening of the tissues themselves. The muscle itself will be shortened, and there's little we can do to kind of lengthen that again if it's been for a number of years. Again, that's why it's important at Atypical Clinic, if people are getting assessed early, we can put in strategies to try and more prevent things like this. So at a basic level, we're just thinking of just general kind of range of movement exercises, where you're making sure you're taking a joint through the movement that it should be going in, doing that every day to make sure you're maintaining that range. If you can't do that, taking it to where it is comfortable to do so, and stretching. So with a stretch, you want to be holding at least kind of 30 seconds. If that's not tolerable pain-wise, you can start small and slowly build that up. A lot about positioning as well, what position is it in for the majority of the day. So yes, you can stretch, but that's really only for a really small part of the day. For the rest of the 23.5 hours of the day, it's in another position. So it's thinking about the position it's in all the time. Can you just position it better when you're sitting? Can it just maybe a hand be flatter on the arm of the chair? Or do you need specific splints and things that might keep it in a better position? Carers or family can be quite involved here. They might need to help move the arm or help put a splint on. So a lot of education around about that as well. And even just then being able to monitor that, and again, if it's early on, saying to the person, oh, make sure you're not keeping your hand in that position or your arm in that position. Not just hands, we see arms and things, and again, kind of arms that might get quite stuck to the side and a bit sore to kind of lift up. So again, important to kind of make the shoulder and the elbow kind of move through its range throughout the day as well. Again, you don't want to run into complications later on where you've got an arm maybe stuck quite down at the side and you can get problems with hygiene and things like that, and dressing and things. So again, important to kind of move throughout that range, a bit of a stretch, and then excuse me, general positioning throughout the day. The only thing I was going to add, we do refer on to specificity clinic for them to assess if Botox is appropriate or not. Not always with success, so it's for a trial of that, and it certainly have had some good results, but not always with CBD.
Okay, lovely, thank you. It's great. I've come across people who've said that they've had real problems with their hands.
Yeah.
And is there anything? Do you have any hints or tips of how they can open those hands, even for hygiene purposes, to help with cleaning?
Yeah, I think again it's about positioning throughout the day. You can stretch and take it out, but if it's just automatically going to ping back in, then that's a difficult one. So positioning, so you might have a splint. If it's hard to get a splint in, it might just be something as simple as a balled up sock. Sometimes if you can't get anything in, you want to make sure your nails are trimmed as well. You don't want a hand that's stuck in and the nails are digging in. So you want to make sure that kind of thing is kept on top of. But yeah, something soft and thing can be put in place, or a specifically made splint. But ideally, the best thing is catching it earlier, so we're preventing these things. But if something's quite stuck and it's been for a number of years, that becomes difficult. Again, Botox maybe becomes a bit more not useful then, because it's the actual muscles shortened as opposed to the spasticity within the muscles. But kind of splinting and positioning, I would say, would be the main things, and just trying to get some kind of lift, and can you slowly stretch that over time.
Okay, brilliant, thank you, that's really helpful. Okay, so this is the most probably different end of the scale. Somebody's asked about some tips on impulsivity and falls management.
Okay.
This will be a PSP question, I believe.
I would think yes. Impulsivity, I think I find that quite hard to manage, because you can't be with somebody 24 hours a day, and quite often you can have that conversation with somebody about how to do something, and you can practice it with them over and over again, but actually when they're sitting at home and something comes into their head, or they need to go to the toilet, they're up and off and the chair's thrown back and they're falling forward. So a lot of, I would say, impulsivity wise, is education as early as possible, and education for the caregiver and things as well. A lot of caregivers strain, I would say, with impulsivity. Again, just because they can't be there all the time, and if they're there, a guilt, they're all the day, turn their back to make a cup of tea or go to the toilet, and the person's fallen, then a lot of strain on the carer from that, kind of needing to watch them all the time. So trying to make the environment as safe as possible when they do get up. What's round about them? Are they likely to go head first into a wall, or do they got their aids close at hand? Appropriate aids if they do. So environment can be huge for the impulsivity, I would say. And then again, just kind of breaking things down for people, and trying to, again, the earlier the better. If you can break the movement down a bit slower into component parts, instead of getting up out the chair just trying to fire themselves forward, if you can slow that down and get them to come to the front of the chair, get them to push up, and get them happier coming forward, and breaking it into those component parts, can be useful, but again, sometimes in that situation, spur of the moment, it's difficult for the patient to actually utilise that.
Yeah, I think it is, isn't it? I mean, when somebody falls, are there suggested ways of getting up, safe ways? Because I know that carers want to just get them up.
Yeah.
But is there something you can teach people to help them with getting up, maybe?
Yeah, I mean, obviously the first thing we say fall is actually trying not to panic and taking your time. Just it's okay to sit on the floor for 5 minutes and check you're okay and check you're not hurt, and just let you get your breath back and make a plan. Again, ideally, if you've been seen earlier by a health professional, you hopefully would then have a strategy that you would use within physio. We would do backward training where we start with people, we teach them how to kind of high kneel onto maybe some cushions and things, and if they can get up from that safely, we make it lower and lower. So we're not just immediately putting them on the floor and, oh, you can't get up. We're kind of doing it step by step, and then teaching them how to kind of do each step and do that safely. And if they need to practice one step and then come back and continue with that, we do. So yeah, making a plan for at home, where if you fall here, very few people are going to be able to just fall in the middle of a room and be able to stand up from that room without some kind of support. So am I going to try and get to the couch, the chair, something sturdy that you can put an arm on, again for safety for you, but also so your carer or family or support aren't hurting themselves by hoiking you up. So if you can be kind of a bit calmer and take the time and have a plan already there, I would say that's the most useful thing, but certainly something we would definitely look at, as long as again it's safe to do so. There are some instances that I wouldn't get somebody on the floor because I know I wouldn't be able to get them back up, but again, the earlier the better, I would say.
Thanks, Fiona. Okay, so have you got any advice on stand to sit? This person is saying they have a few patients who hyperextend, so struggle to flex their hips and knees to sit down.
Okay. I think probably quite common, especially with PSP, they tend to be quite rigid and quite straight back, and their knees don't want to bend. They tend to just sit down as a one thing, fall backwards into the chair as opposed to, like you say, flexing. So again, the earlier the better. Lots of practice with sit to stand, again, lots of teaching carers or whoever's with them at the house what they should be doing. You can use maybe some visual cues. Can they reach for something to bring themselves forward? Can they reach down their leg to try and again bring their weight forward and flex at their hips and their knees, and just that kind of working on their trunk kind of rigidity. So they're really quite rigid in their trunk, and can you work on that? And even in sitting at first, can you work on reaching forward and practice with the stand to sit, and then just reverse it when we're coming back down. So lots and lots of trunk stuff, I would say. Again, in standing, it depends what stage they're at, how good they are, maybe cognitively, how engaged they are. If someone's really hyperextended at their knees, and probably a bit physio talk here, they tend to be a bit tilted at their pelvis. So if you can get them to tilt the opposite way, it tends to release their knees a wee bit, but they probably have to be quite aware of what's going on at their hips to be able to do that. So not everybody maybe would be able to, but maybe lots of cues, lots of visual cues, lots of prompting and lots of training for whoever's around about them, just to kind of reinforce that. And again, the earlier you can start it, maybe as they're starting to show signs of not flexing, just trying to kind of introduce that earlier.
Excellent, thank you. It's everything you say makes sense, in as much as we've got to be encouraging people to do those exercises. It's no good just doing it once. You've got to repeatedly continue. Okay, so we've got somebody's asking here have you got any tips on backwards leaning during or within a gait? So I suppose this is where we've got the opposite now to the person on the front of their feet. Now we've got people on the back of their feet.
Yeah, and again, that I would say more common in PSP. Their weight tends to be to be shifted back, maybe on their heels. Again, for myself, again, it depends kind of what stage they're at, how they're managing. Lots of balance kind of stuff, lots of reaching stuff, and trying to get a bit more aware of where their centers of gravity should be. You can use try heel wedges. So just putting a wee wedge at their heel just to slightly, and I'm not talking like a big wedge, but even like a wee wedge, or even just a big thicker heel of a trainer or something, just slightly brings them forward. I would say it doesn't work for everybody. I've had somebody that loved it because they just felt that they just were enough forward that they didn't feel like they were falling back. I've had somebody that really didn't like it because they just felt it through them. They felt like they were coming forward because they were used to being a bit back. So when they came forward, they felt like they were falling forward. So something worth trying with somebody, certainly worth trying with a physio, not just sticking some wedges in your shoes, because it might throw you more off balance. But it's worth a try if someone's really struggling. Obviously, if it's impacting on their safety and we're not managing to progress that, then an aid will probably bring you forward if you're leaning on to something. But aids sometimes present their own problems, and sometimes get in the way more. But if you can lean on to something that can be helpful as well.
Okay, lovely. Well, that leads us straight into questions about aids, which is quite useful. Okay, so somebody's asking specifically about U-step walkers, or the use of gutter arms with an aid. Is there a value? Do they help people with PSP?
We're saying it earlier that I U-step walkers is something that I've only really been introduced to within the past couple of years within this specific client group. It's not something that's widely available. They're quite expensive. Quite often the NHS don't fund them. So yes, they're used. So they are more weighted, and they're heavier. They're more sturdy than your standard kind of four-wheeled walker. It's essentially a four-wheeled walker, but are certainly more weighted. They have a reverse braking, so you, instead of pulling on the handles to go, you pull the reverse of that. Instead of you pull the handles on to go, and then so that then if you let it go, the brakes automatically come on, which is useful if you're coming to a quick stop and then or get a fright or something. People tend to let go, and then with ordinary walkers it might kind of just roll away from them. So that can be useful to the reverse braking. The other thing that I find quite useful, especially with the PSP, is you can I don't know this technical term for it, but add resistance to the wheels, so that you have to actively push it against that resistance, so it slows everything down. A normal kind of walker, four-wheeled walker or something, just has kind of free wheels that quite often people feel run away with them, especially like say if you've got that feeling of coming forward, that might run away with you. So the kind of resistance to that braking slows everything down a wee bit, and it's just much sturdier. The gutters obviously is keeping you upright a bit more, quite useful if you, especially with perhaps CBD, if you've not got a functioning arm, because you don't have to be able to do two breaks. If you can do one break, that's fine. Again, in a normal walker you have to be able to do both, otherwise it'll knock you off. But just one of the breaks is handy for that. Or if you can't hold on, then the gutters are more useful, and obviously just give you a bit more stability around about your trunk if you're using a gutter as opposed to a frame as well. So they definitely have their place. As I've only issued one that we've been allowed to issue, but they're certainly a lot sturdier, and I would say for my very impulsive patient was the one that we tried to get it for. It actually did do well for him. It slowed him down a lot, and once he was up, he was able to stand with it. With his other walker, he was quite big and brash, and when he got up and went, he just had to go because his walker just went. So it really slowed him down and was really quite nice from that point of view. There are also many other aids out there as well, and you don't always have to have a U-step, and certainly we don't have access to that. So although I'm saying the four-wheeled walkers can run away, they certainly have their place as well. But an appropriate aid should be assessed by a physio, so that you're knowing what's appropriate for you. Do you need something in one hand? Do you need something in two hands? Do you need something? Do you know how to work the brakes safely? Do you know how to kind of put it up and down? All these things.
Excellent, thank you. Yeah, a lot of good tips there, because when you were saying about it being weighted at the front, somebody asked us about weighting four-wheeled walkers safely. Can you?
Apparently you can. Again, I've not done it. So I was speaking to a physio down south that is, I think you may know, is heavily involved in PSP and CBD, called Jade Donnelly. So she was saying they've got a charity down there somewhere that they can refer to, and they will weight the walker safely. I've not heard of that up in Scotland. I will certainly look into it, but I've not done that. I've had people that maybe come in and, oh yeah, we just stuck some sugar in the basket, but obviously you're just weighting it at different points, and really you're probably more hazardous to tipping, or if and probably not as safe, and not something we would advocate for you to do. So if it's going to be weighted, it would have to be something like that, but I don't know where up here would do that, but apparently you can.
Okay, excellent. Well, I think what's important there is you saying, yes, it can be done, but by a professional.
Yes. yes.
Yeah.
Maybe not try random things yourself.
Yeah, absolutely, definitely. You touched on it very, very briefly when we talked about the U-step. Then people are asking about if you've got any tips or hints or ideas. People with one-sided CBD symptoms, so they've got one working hand and arm, as you and I have too, but their other one, unfortunately, they've got alien limb symptoms, so they're finding that they've got no strength or dexterity, or the hand won't do what they want. And then they're struggling with two handles on a walker or an aid. Is there anything that can be done, do you think?
I think this is probably an age-old question with physios, even when it comes to if somebody's had a stroke and can't use one arm and things like that. We often run into problems. So obviously using an aid just on one side, so a crutch or a stick or something, is the first obvious thing. But obviously if they need more support than that, a gutter frame would be the kind of first, or the kind of choice that you would think of, just so they can put their forearm on that. They don't, ideally they would want to grip as well, but if they could just put their forearm on it. You do get pulpit frames as well, so you can just kind of more lean their forearms on. Don't give them out that often, but I certainly have done. They can be useful if someone's needing a lot more support but can't hold on. If they'd have a bit more use of the arm, but the hands just function, just not able to do so well, there is a kind of, again, I'm not sure how widely available these are, but we certainly have them up in our department, where it's like a special thing made for the Zimmer that you can put it on, your hand just sits in it, and you can put that on a Zimmer. But no, it is a tricky one all round, not just with these conditions, but yeah, gutters and things, I would say, would be the main thing if you're needing that level of support.
Excellent, lovely, thank you. If you don't mind, I'm just going to slip a question in that you don't know about, but you're more than capable of answering it. It's not a problem. It just makes me think. We often get this question on the helpline, and it's something I'd like to ask you. As people progress with PSP and CBD, but I think we hear more with PSP, when sitting in a chair or in a wheelchair, we find that they start leaning to one side, and then obviously that causes problems of its own because it's putting pressure on the one side. Are the things that can help with that, or be it exercise or some kind of adaptation to their seating that can make it more comfortable for them?
Yeah, I mean, again, I suppose from a physio assessment point of view, I suppose the question is, why are they doing that initially? Is it a weakness they've got there? Is it an altered awareness of their posture, position in general, or is it just comfortable? Are they sore? Are they? So I suppose from a physio assessment point of view, it's trying to work out why they're doing that. If they're sitting in a wheelchair all day and they're quite weighted on one side, I suppose just making sure that they've not got any skin problems when they're sitting and need a a pressure relieving cushion or anything, just to make sure that's not a problem. Like all the things I spoke about, ideally you are seeing people earlier on and doing some kind of more trunk stability work, so they're able to move a bit easier. Yes, exercises we can do to do some reaching to the opposite side, trying to get a bit more engaged at doing that. Some mirror work, you could use some mirror work to make them a bit more aware. Can they in the mirror correct that themselves and doing that as an exercise? So you can do that. If they can't do that, then wheelchairs can, not just a standard wheelchair, but if you need an adapted wheelchair, you can get kind of lateral supports that come in at the side that will keep you in a more upright position. Because obviously if you're, like you say, if you're in a position that's kind of slumped or to one side, then you can get complications of that in itself. You might get sore to one side or shorten the muscles one way and lengthen the other. So just to get sitting in a better position is ideal. So yeah, you can get supports. If the people are doing it in general, you can just roll up pillows and things and just give them a bit more support. That's what, if you maybe saw someone in hospital and they didn't have their own wheelchair, that's what the first thing we would do, is just get them into that middle position, but with support from pillows and things, so that they're well supported in that position. But they can go on to get adaptations done. Yeah.
Okay, lovely. Thank you. Right, just thought I'd put one in at the end.
Thank you.
Always you don't know, but I think that's been really helpful. I think we often get calls from people about physiotherapy and the value of it, and they say, well, can a physio do something for me? I think you've explained that yes, physio can do an awful lot for somebody. I suppose often what people think with physiotherapy is they think if their walking is starting to become a problem, they want it to go back to how it was.
Yes.
And I think it's it's understanding that you can help support how they're walking at present, yes, as opposed to put it back to what it was, really, isn't it?
Yeah, and I think it's gaining that understanding or getting that message across that no, we're like you say, we maybe can't change their walking back to what it was. But we can also improve things as well, especially the earlier we see people, getting people exercising again. Some people maybe have problems and just stop doing everything. So actually, especially if it's early, you can get introduced exercise again and do balance stuff, do strengthening stuff, do aerobic stuff, then we can see improvements there. But like you say, sometimes it's difficult for maybe families and things to understand that they've been doing all these exercises, but their balance isn't 100% again. Why is their balance not getting better? And sometimes it's about, yes, their balance might not get 100% better, but actually it's not got worse over this, even just 3 or 4 months. Whereas if we hadn't been doing the exercises, it might just show that the curve is steeper if we don't do the exercises. So it's trying to keep things as good as we can for as long as we can, keep people's quality of life as good as we can. And exercise as well, sometimes kind of having to think about the fatigue management side of things as well. You can't, not going to bombard people with exercises and then they can't do the things that they want to do. They've done 100 exercises, but they can't go on the walk with their daughter or their mum that they want to go on. So it's finding that balance for people as well, so that they've got that quality of life is important as well.
Excellent, brilliant. Fiona, that's been really helpful. Every day is a learning day, and I think as always. So I'd just like to thank you very much. Hope it went okay for you. It wasn't too it's never easy in this scenario, but I think that, you've given some really good hints and tips there. So thank you very much.
Okay, thank you very much. Thank you for all your support as well. I'd also like to say a thank you to, I spoke to Jade Donnelly, so she was also saying that there's a PSP, is it an advice book or guidance book for physios that's going to be online soon?
Yes, absolutely. Yeah, good plug. Yeah, it's yeah. So at present we have a professional's guide for occupational therapists, but it was apparent that they're two different jobs, and we do know that. So we've now created a professional's guide for physiotherapists, which should be available from the end of this month. So Fiona and I are recording this at the start of January 2023. So that is something that will be available. And hopefully that's going to just reinforce everything you've already said. And, if people watch this and then they can contact us and get one of those guides as well. definitely.
Great.
Okay, lovely. I shall see you again.
Okay, thank you very much.
You're welcome.